All right. This case is about a new two-tall T-wave in V1, which is one of the things to think about when we're worried about occlusive MIs. Now, I may have shown you guys this case before, like in real life, but I want to put it on here because I'm going to be referring to this often in the future, and I think it's good to get exposed to it now. Now, I was also reading some stuff on education. Apparently, if you're entertained, you're going to remember more. I believe that certain stereotypes among doctors are true. And for ER doctors, all ER doctors I know either number one, have ADD, or number two, have an expensive, dangerous hobby, like mountain climbing or something like that. My expensive, dangerous hobby is number one, collecting ex-wives, and number two is forging knives with my kid. We're trying to build a power hammer because power hammers cost like thousands of dollars. So we're trying to build this, which is a Da Vinci cam from the man Leonardo da Vinci. This thing spins around and the hammer goes up and down and smashes. So we'll see if I get out of this with my fingers and my 401k intact. Now, for the case. This was a case I saw a while ago, a case of chest pain. Remember, you don't treat an EKG, you treat a patient, and the value of any EKG depends on your pretest probability. So this is how we get our pretest probability. Patient is a 55-year-old male presenting with ED for chest pain, history of coronary disease. Said he was doing yard work at 5 p.m. And yesterday when he felt like his whole body was overheating. He states he went outside his house to cool down, but a test he began having chest pain 30 minutes afterwards. Okay, patient endorses having pre-existing and constant chest pain, making it difficult for him to sleep at night. He states he feels short of breath with movement and endorses nausea early yesterday. Patient reports he smoked a pack of cigarettes every day. Not good. He has been taking his blood pressure medications, though he does not take any medications for his diabetes. He endorses a family history of heart issues, with his mother having stents, awesome, and his father having a bypass. Patient attests to a history of attempted stent 3 years ago, though he states it didn't take. Patient denies any of the concerns or complaints at this time, right? So high pretest probability, right? Like he has known risk factors, high blood pressure, known coronary disease, diabetes. He's not really taking his medications, and he's had a heart attack before, and he's got symptoms with exertion, right? He was doing yard work, and that's when he had his problems, right? So high risk, high pretest probability. First EKG, and we have nothing old to compare it to, okay? Number one, pause, look at it, write down what you think. Write down your findings, and then also think about your interpretation, okay? Remember, the definition of interpretation is the action of explaining the meaning of something. With this pretest probability in this history, we need to explain the meaning of any findings. All right, so here's what I think. Number one, definitely normal sinus rhythm, right? Like they call this strip at the bottom the rhythm strip for a reason, and just read it from left to right. Like, yes, there's a lot of artifact and stuff going on here, but the question is, well, do you see 1P for every QRS? And if the answer is yes, it's normal sinus and move on. I mean, he does have some atrial abnormalities. You can see this peaking of the T waves, the P waves in 2-3 and AVF, and this biphasic P wave in V1 and V2. Like this biphasic P wave in V1 and V2 is very suggestive of left atrial hypertrophy. Okay, the axis I would say is normal. Okay, I would also say it's safe to make the argument that we have a fractionated QRS or a delay in the QRS in lead F that's not a block because it's under 120, which is suggestive of some type of structural heart disease. With this gentleman, with his history of smoking and this atrial abnormality, I would be suggestive of some kind of valvular problem. Because remember, the valve is electrically inert, and as the valve stretches, it takes longer and longer for the electricity to go around it, which can cause like a fractionated QRS. But I mean, who really cares? The main abnormalities in here are there's repolarization abnormalities, okay? And we have focal repolarization abnormalities. Number one is the precordial leads. We have an upright T wave in V1, which you're not supposed to see. Like it's supposed to be inverted. We have this super tall T wave here, and we do have slight J point deviation, okay? Remember, in my opinion, when you're worried about infarction, ischemia, coronary artery disease, you got to compare the J point to the PR segment. The other way to compare the J point to the isoelectric point is the TP segment. I mean, because there's two ways to define the isoelectric point. One's the PR segment, the other is the TP segment. For me, I recommend using the PR segment because we'll see in later cases that the TP segment is not as reliable as the PR. Well, I'll get into it right here. I mean, you can see it over here in lead 5, okay? Here's the PR segment. When we look at the J point, it is like slightly depressed. You'll notice over here we have this downsloping of the isoelectric point and the development of a U wave. Both of these are concerning. This downsloping of the isoelectric point is referred to as Spodek sign, okay? That's a repolarization abnormality you normally see globally in the setting of pericarditis, okay? But for me, when I see that sign focally, especially with someone who has a high pretest probability for coronary artery disease, it concerns me. I mean, because, well, might as well talk about it now. I mean, you can see here, in V5 and V4, you can see the isoelectric point from the end of the T to the beginning of the P downslopes. Like, look at the rhythm strip like it's a perfect straight line. Like, the end of the T to the P does not change at all. And again, so that's the thing is if we look over here at V5 and we extrapolate out the TP segment, and when we follow it back like it goes up here, like that's why I always recommend using the J point, or the PR segment for the J point. So we got upright T wave in V1, hyperacute T wave in V2 with J point elevation. We also have a hyperacute T wave in V3, maybe a 0.5 millimeter J point deviation. And like we talked about before, slight J point depression over here in these hyperacute T waves. Now, the first question is this a STEMI? And the answer is no. Okay, he's over the age of 40, so according to the guidelines, he has to have more than 2.5 millimeters of elevation of the core leads, and he doesn't have that. I mean, he's got elevation, but it's only in one lead. And the other thing is, what makes a hyperacute T wave? The summary is there's no definable point, okay? My recommendations is not necessarily to look at how tall the T wave is, but look how tall the T wave is in comparison to the QRS and how narrow it is as well. Like if we take this whole QRS and were to copy and paste it, we can almost put this whole thing under here. I mean, this one we totally can for sure, right? If we took this whole QRS, we could fit it under here. That's an Amalma-2 thing. That's definitely hyperacute. Okay, so far we have this patient, high pretest probability. We have these focal repolarization abnormalities. It's not a STEMI, but very concerning. The last thing is, and the whole point of this case is the T wave in V1 is taller than V6, which is not what we would expect. Here's a repeat EKG a few minutes later. We do have the development now of T wave inversions in lead 3 and lead AVF. We have these same hyperacute T waves. Now you can see V1 is much more bigger than V6. We have the same J point deviation in V2. And now we have, again, slight J point deviation in V3, but again, doesn't qualify for an infarct under the most current guideline recommendations. So for this gentleman, I was highly concerned. I called him a STEMI. The cardiologist canceled it, and here's what ended up happening to him. So here's his first troponin, 2,048 at 124, 3,000, and at 9:30 the next morning, 20,984. He goes to cath, and he's got lots of pathology. I mean, you can see up here the coronary artery disease, the stenosis, and the lack of flow. Severe multivessel coronary artery disease. Here's more pictures of it. I mean, you can see that severe stenosis, lack of flow. Oh, that's bad. And here we go. Left ventricle appears normal size, increased LVH. We got a reduced ejection fraction. Okay, that's the main point about this case. So the whole thing is the most current thinking, the most current dynamic is that STEMI needs emergent revascularization. Okay, STEMI, in my opinion, is an antiquated term. STEMI is a relative term. Like the answer for what is a STEMI depends on who you're asking and where you're at. Like the STEMI criteria for America is different than Canada than it is for New Zealand. So for me, it's not, does this patient have ST elevation? It's, do they have symptoms, risk factors, and focal repolarization abnormalities? For me, that's a trifecta. When you have those three things, symptoms, risk factors, focal repolarization abnormalities, it's not a question of does your patient need a cath, it's how soon do they need a cath. Because the issue in medicine is time is our most valuable resource. Like, it's the one resource we can't control. Like, once time is gone, it's gone. Like, I can't consult more time. I can't order more time from the pharmacy. I can't do a procedure for more time, at least not until my flux capacitor is working. But short of the story is that's why I'm aggressive with coronary heart disease. Like, coronary heart disease continues to be the leading cause of death in America year after year after year after year after year after year. My contention is, why wait? When we have symptoms, risk factors, focal repolarization anomalies, I think an emergent cath is totally indicated. That's all my thought processes and all what I think about. And again, in these videos, I'm not doing this to try to convince you that I'm right. I'm doing this just to get information out there. Like, I'm telling you the way I practice and why. If you like it, great. If not, like, don't listen to me. Like, I don't care. I'm not like a world-renowned specialist. I'm just a guy who practices medicine this way because of what I've read. So that's all I got. No, that's not all what I got. So that's more problems with his coronary artery disease. Looks very, very bad. What does the literature say? Okay, what is a new 212 T wave in 1? While normal EKG has a flatter inverted T wave in V1, a new 212 T wave in 1 can be an early sign of ischemia, hyperacute T wave. Upright T wave in V1 is abnormal if the height of upright T wave in V1 is taller than T wave in V6, or a new upright T wave in V1 compared to old EKG. Now, here's the thing. This is a non-specific finding, okay? Like, you can have a T wave in V1 bigger than V6 for many other reasons. And remember, I'm going to say this a lot. You don't treat an EKG, you treat a patient. And on EKGs, there's abnormalities, but you have to have symptoms plus abnormalities to have pathologies. It happens all the time in the department. Someone brings an EKG up to me and they're like, look at this inversion in AVL, look at this terminal R wave, look at this lead, look at this T wave in V1. I'm like, well, what's going on with the patient? Oh, he's 32, he wrecked his scooter and has an open fracture. Does he have any symptoms of chest pain? No. Does he have any risk factors? No. Well, then it's not relevant. I mean, is it abnormal? Yes, but is it pathologic? Not in this case. That's why I would have it motioned to be removed from the record. As a joke. Same thing from this paper, which you guys can read at your leisures, and or you can look up online and go through it more thoroughly if you want to. Here's examples from these cases, and I'm sorry about the quality here, but you can see here's the baseline EKG. The T wave is normal appearing, like flattened or inverted. V6 is mildly. Here's when they're having pain, okay? Now you can see the T wave in V1 is in bigger in V6. Here's from Amal Matou's book. Again, you can see this T wave in V1 bigger than V6. And also note this, ST elevation is morphology here. Also note this slight inversion in linearity in AVL. Man, that's a good EKG. And here's another one from WestGem. Again, look at the T wave in V1. It's upright and it's bigger in V6. Again, look at this hyperacute T wave, right? Like, we can take this whole QRS and put it under that T wave. Same thing here. And again, note the linearity, right? Like, if we were to cut and paste this T segment and compare it to the amp of the QRS, it's over half the size of the QRS. Same thing in lead 1. Like, look at this linearity outside the baseline, especially compared to the amp of the QRS. And again, we have that flattening in AVL. So that's all I got for this case. Sure, the story is a new 212 T wave in V1 in the proper setting can be a sign of coronary disease and may need urgent emergent revascularization. Hyperacute T waves, there's no set definition, but focal repolarization abnormalities are concerning. Okay, so that's the way I think and the way I practice. Symptoms plus risk factors plus focal repolarization abnormalities equals cath. The question is, how soon do they need it? For me, clinically, it goes on their appearance and their symptoms. If they don't look that bad and I can control their symptoms, with nitroheparin, aspirin, pain medications, then I'm okay with waiting. If I can't control their symptoms or there's dynamic T waves, I push very aggressively for an emergent cath. But that's just the way I practice. That's all I got for this case. Hope you enjoyed it. Again, any questions, ask me in person. Peace out.